we're going to kind of mix two practices in with this one. We're going from very basic airway management, cardiac arrest, because those two will intertwine with one another. With any question of someone who's like, let's say they're in respiratory arrest, you don't want to just use these devices. You want to use a BVM because they're not going to be breathing independently. So if you don't force the air in, then very little air is going to get in. So respiratory arrest with a pulse still, we'd be using that BVM, which you'll be able to practice with in future skills labs. The same goes with the oxygen administration equipment. Especially with cardiac arrest now, there have been some studies that show that if you place a non-rebreather, which is the mask with a bag, and there should be holes so that you can breathe in atmospheric air, if you have a non-rebreather on them and you're pushing on their chest, you actually will create some negative pressure to force that oxygen down in there. So especially where it's one person CPR, or maybe you are part of an advanced life support team where the other person is focusing on delivering medications. An advanced airway should be the very last thing we worry about. It is acceptable to do passive oxygenation in the presence of compressions with a non-rebreather. So that would be the only time we're putting on the mask to a person who's not breathing. So in this case, passive oxygenation, I'm the only one here. I'm doing my compressions. Now, as you can see here, this cot is too high for me. I should actually be in a position like this so I can lean over the patient, get my arm straight, and my goal is to have an arm that looks like shoulder over wrist. So that'll give you a firm support. If you try to do compressions like this, you're not going to be able to put your body weight behind it, and you're not going to get a lot of pressure down on the chest. So you want to lower the patient as appropriately, or do it on the floor. Take him off a bed because you're going to be just collapsing the bed. So we're doing 30 to 2 breaths, or in the case of you're the sole one waiting for your partner to come running back in, you may just do continuous compressions at 100 to 120 a minute. As soon as we can, we do want to put paddles on them because we know that only two things work in resuscitating patients who are in cardiac arrest. One is defibrillation and the other is quality compressions. Everything else is a guess. So one of the things that I see, and the reason why I provided these pads to you, is people will put these on wrong, especially at the EMT level, or on a cardiac arrest with a newer EMT. Adrenaline's running and they panic. So I've seen every iteration of the wrong way of putting these on. So what I encourage you to do is just to practice over and over again, looking at the pictures and placing it in that diagonal formation. There are other formations that you can utilize, front and back, but we're not going to worry about that right now. Let's get one down of muscle memory of I'm just going to always go to the left lower and the right upper, and getting that, we call it lead 2 because that is lead 2 on our monitor, but that just diagonal formation down every single time so you're doing it correctly. So the cardiac arrest has been ongoing for a while. I want to secure the airway, and I'm going to use my airway devices that I have in order to do that. Now, some providers will use 2 NPAs and 1 OPA and plug all holes. I wasn't trained to do that way. If you want to plug every hole you can because you can, that's fine. But 1 should be sufficient. They're made to operate on their own, not together. So you want to lube this up. Don't use your mouth, it's disgusting. Use some actual lube, and then just making sure the bevel's on the inside toward the middle of the nose. You're just going to insert it and then gingerly twist it down all the way until the trumpet portion of the NPA meets the patient's nose. And poor little Johnny here has had a lot of action, so I don't think it's going to go all the way down on him. In any case, once you have that inserted, it should be able to then push air past that tongue that may be obscuring the airway, and then it will help that rise and fall of the chest. OPAs, we measure from the ear to the tip of the mouth, making sure it's an appropriate measurement. Generally 70 or 7 and higher are the appropriate for adults. Now, you can either do the straight in way or there are some that go in the 180-degree twist. I'm a straight in person, so head tilt, chin lift, and just straight in until that trumpet part is at the edge of their teeth or their lips, and then you begin ventilating them. So that's the BLS airway, right? We're letting the AED tell us when to pause. We're checking when that AED does tell us to pause to read that rhythm to see if they have a pulse. We're clearing the patient, all clear before we push shock. And I'm sure you can pull up a video of the AED talking and you can practice with the actual AED. When you do National Registry, you'll have to do at least 2 minutes of compressions. So getting a little workout in, getting your body used to being over the patient and compressing. If that would fall and I'm alone, send help. Finally, for our advanced students, we are going to eventually be able to put an advanced airway in. Now, we know that science tells us that this no longer is as important as the rest of the stuff. So if this is going to inhibit your ability to do compressions or to shock the patient, then we don't do it. But if you have the time and you're able to do it, or enough providers, then certainly get an airway down. And this actually would be the airway of choice for pre-hospital, would be the blind insertion airway device. Paramedics will still intubate, but we're finding that those intubation attempts delay other things that need to be happening. So we're trying to push away the focus of attempting to intubate. So when you do put any airway device in, remove those adjunct airways. Even those NPAs, if you've gotten a really large size and shoved it down there, can get in the way. These two might be rubbing together and it might obscure your ability to push it in. So clear the airway. Again, head tilt, chin lift. You want to put them in a sniffing position, which is their head slightly back and nose to the sky. It's kind of like the snob position of their head. So hyperextending that. And then blind insertion airways are super easy because you just stick them until you meet resistance. So with your styrofoam head, you're just going to be shoving that in there until you meet resistance. So now I can't shove it in any further, so it's seated appropriately. And then you want to take your syringe and inject air into your balloon. And then once that air is injected, you're able to put the BVN on and watch the rise and fall of the chest. And that's how you're going to know that you're in the right spot. The King airways specifically are measured by height. LMAs are measured by weight, so you kind of provide a guess for that. The size 4 King is between 5 and 6 feet, so generally most of our patients are that. Some King airways will have an extra port where you can put suction down with a flexible suction tubing and suction while you ventilate. This one does not. Some of your LMAs may have that too, but that will just help with the overall stomach contents regurgitating. Otherwise, anytime you put an advanced airway in, what we want to see is you having all your other plans in place. So this isn't going to protect you or be able to suck up vomit. So you want to have suction at the ready. You want oxygen flowing at a high rate. Maybe you were doing CPR with a nasal cannula at 15 liters, and that's how you're oxygenating the patient. Keeping that going. Having a BVM ready. Don't wait until this airway goes in to get your BVM out, because that's not going to be acceptable. You want to have 2 ways to confirm that advanced airway. So we want a colorimetric CO2 detection device, a bulb device, which isn't as popular now, it was in the old days, or a waveform capnography is considered the gold standard, where we're plugging it in, as we saw in class, to the monitor and seeing that nice, beautiful waveform. We also want to have a stethoscope at the ready to be able to listen to the stomach first and then to the 4 points on the lungs. And someone will be ventilating quickly so you can listen. If anytime you hear stomach bubbles, then it likely means that this needs to be repositioned. It will happen less frequently with a King airway device, but it is possible, given that they're breathing through this little bubble right here, that you may have to rescind it a little bit, that maybe you got it too far down in the esophagus. So in the case where you're hearing all the air going in the stomach, you would deflate the balloon, pull it out just slightly, reinflate, and then try to push air back into the lungs. So that's that basic management of that. We want to make sure that we can do those compressions for at least 2 minutes. whether it be for national registry testing or in our real professional lives. I do see that as one of the failings of a lot of EMS programs is we have some people that just aren't physically capable of doing the job. So we want to make sure that we practice and condition our bodies to at least do those 2 minutes. And that some of that is cardiovascular conditioning, going for walks, but the actual practicing of that movement as well. Moving from a lower amount of oxygenation intervention to the highest amount would be the advanced airway. Whether you're a basic or an advanced, you want to always focus on the least invasive to the most. We don't just jump to the most invasive because we can do it. That doesn't make you a good provider. Even I, as a paramedic, should be able to intervene at a basic level before I'm going to the ultimate step. And if I'm just skipping because I can do it, then that may not be what's best for the patient. So good quality compressions, getting that AED on in the right formation, securing the airway as appropriate. That's what those skills are really about. And then the biggest thing with any airway adjuncts, again, is you could just do the straight in with the OPAs or with the NPAs, making sure you lube it up is the most common mistake that people make before they insert it. So that would be it.